do some good. The goal is to support the cartilage rings, preserve the blood supply and nerve supply to the trachea. So you got to be really delicate about dissecting around if you're doing extraluminal. Intraluminal, they just pop it in kind of like an endotracheal tube and expand it and you're done. So you don't really, surgeons don't usually do those. Internal medicine folks usually do the intraluminal stents, okay? You got to think about whether you need to do it cervical or proximal interthoracic, okay? Sometimes you have to do both. Sometimes when you stent the cervical, then the interthoracic starts to collapse, okay? Intraluminal stents, any location, there's less risk. The blood nerve supply, like I said, just pop it in like a endotracheal tube. But you really need fluoroscopic or endoscopic assistance. They can have severe complication, and both of these are considered salvage procedures. We're not curing them. We're helping them breathe better, okay? We are not curing them. So here's showing how you do so those are the little plastic extraluminal stents made out of syringe cases. Make them 5 to 8 millimeters wide, 5 staggered cones, smooth edges. You can autoclave them or gas. Sometimes this plastic will melt with autoclave. If you gas sterilize them, you got to let them sit for a while and air out, okay? Because the plastic will retain some of the ethylene oxide and it can be toxic. You approach them in the cervical midline, you go through the sternohyoid and the sternocephalicus. Be careful of recurrent laryngeal nerve. 1 to 2 distal to larynx, and then every 5 to 8 millimeters apart, so every 5 to 7 rings. All right. You're going to tunnel around the trachea to preserve the blood supply and the nerves which are coming in from the side. You secure with 3-aught or 4-aught proline, lateral, ventral, and dorsal. Make sure that you don't hit your cuff on your endotracheal tube when you're putting these in. All right. Radiopaque marker at the last ring, and then close the muscles. Interluminal, like I say, procedures vary with the type of stent you're going to put in. You need either scope and or fluoroscopy to help assist you in putting these stents where you want them. Do accurate measurements, radiopaque ruler when the radiographs are taken, it helps you. And you want a positive pressure insufflation to 10 millimeters of mercury on the lungs. And you're going to start 10 millimeters from the larynx and carina, okay? So you can go that far down into it. At the thoracic inlet, these things are prone to fracture. They're usually some sort of metal, so you bend them back and forth enough, they'll break. Okay. Open, looped, or knitted implants are preferred so the mucosa can grow into it. Repositioning is not possible and removal is difficult. Okay, so that's the problems with these things. Once again, before, during, and after anesthesia, you have to monitor for acute respiratory distress, inflammation, edema, suture irritation, laryngeal paralysis. Eventually, these guys may need a tracheostomy, all right, even after you've done surgery. You manage them medically as listed before. Usually, we cage rest them for 3 to 7 days, and you may not see improvement for a couple of weeks due to tracheitis. And the trachea is very prone to irritation, okay? So quality of life is usually improved, but like I said, it's not a cure. These are your complications, obstruction, infection. The big thing with intraluminal stents is breakage and migration. Prognosis depends on concurrent problems more than location or severity of the disease. 80 to 90% improve with the extraluminal stent, and same thing with the intraluminal stent. They can have late complications. I think sometimes Fossum paints a brighter picture than I would. All right, tumors. Laryngeal tumors, you're talking about rhabdomyosarcoma, squamous cell carcinoma, adenocarcinoma, and mast cell. Feline, squamous cell carcinoma, and lymphoma. Okay? Anytime anybody asks you about cancer in a cat, those are the two you need to pop into your mind right away. Unless you're talking about brain tumors, in which it's meningioma. Cats do us a favor, okay? They don't get a lot of different weird stuff. All right? Canine tracheal tumors are less common than laryngeal, but you can see osteosarcomas and chondrosarcomas, lymphomas, mast cells, and adenocarcinoma. What external factor could cause a tracheal tumor? Anybody know?
Parasites?
Yeah, what kind of parasite? Spirocerca lupe, yeah. Dr. Anderson would be proud of you guys. So, feline tracheal tumors, you're usually talking squamous cell and adeno and lympho. So you're talking older dogs and cats here, around 10, 12 years old. You have an acute or progressive upper respiratory obstruction, which will give them dyspnea, okay? Stridor, cough, exercise intolerance, same stuff that I've been talking about for the last 2 days, basically, okay? They may have weight loss and lethargy, and you may be able to actually notice a mass. How you diagnose this? Diagnostic imaging, okay? Radiographs. You can biopsy or do brush cytology, you want to do your blood work. If it's a cat, you want to do leukemia testing. Differentials, there you go. Everything else I'm talking about the last couple of days. All right? You already got the parasite. Treatment. Radiation is effective for squamous cell carcinoma, mast cell, lymphoma. Chemotherapy for lymphoma, mast cell, and adeno. And then surgery, tumor resection, and anastomosis, or permanent tracheostomy. Okay? Well, we've already talked about the techniques, so. You can't do a total laryngectomy, but we're going to require you to put a permanent tracheostomy in there, all right? Management and complications is the same as the rest of the diseases. So it's pretty simple, right? Tumors, the prognosis depends on the tumor type. Can run from excellent to guarded. If it's in the laryngeal area, it's usually very guarded or to poor. Also depends on what kind of surgical treatment is required. And that's it. Let's see, I think I have chest left. Let me see how many slides there are for that one. Sorry, I'm kind of flying through this. It's a necessary evil. I think chest is kind of long. Where are you? E-chest? Yeah, E-chest. Any questions on the stuff I've covered so far? Oh yeah, this is 55, so I need to start it.
Where would you choose an intraluminal versus an external stent? Do you have an example when you can choose either or? Maybe for example.
Whether you have it in your hospital and you have somebody that knows how to do it, and you've got the equipment that you can do it. From my standpoint, if I had the choice, I would go with the intraluminal stents every time. It's a lot easier, and you can stent the whole trachea. Whereas with the extraluminal, you're pretty much talking about the cervical trachea. Unless you want to do a thoracotomy and stent the thoracic trachea, you're not going to do that with extraluminal stents. Dr. Martin knows how to do them. We don't do them here because we don't have the stuff to do them. When we get the CRM in, we might start doing it. But again, you need to emphasize to the owners that this is a salvage procedure. We're not fixing it. I really encourage medical management early and aggressively when I see these cases to try to prevent them from getting so bad that they need stenting when they're old. I hope they die of renal failure before they die of this. So. All right, we're going to talk about the thoracic wall, the lungs, the diaphragm, and the pleural space, and the chest, okay? There we go. So, specific problems. Break it down into your damage scheme, okay? You can have tumors, you can have trauma, abscesses, you can have lung lobe torsions. There's some really weird congenital problems. One of them is called pectus excavatum and the peritoneal pericardial diaphragmatic hernia. All right? Those are kind of cool. Pneumothorax, pleural effusion, chylothorax, pyothorax, thymoma, thymic brachial cyst, and mediastinal cyst. So all those are the diseases I'm going to talk about on this one. All right? Trauma, hit by cars. Now think about damage to the thoracic wall, bone, muscle, blood vessels, nerves, okay? Lungs can be involved. The lungs can get bruised. The heart can get bruised. You can have pneumothorax with a hit by a car, okay? You can have a diaphragmatic hernia with a hit by a car, so you got to think about that. You know, abdominal organs will come up and sit beside the heart, cause problems with respiration, cause problems with heart. You know, it can cause kind of a cardiac tamponade if it's confined within the pericardial sac. So you got to think about all that, okay? Don't always jump to the fractured radius and ulna or the femur. Look at the chest, look at the heart, look at the lungs, look at the bladder, look at the nerves. It's great to fix that bone, but if the nerves don't work, you know, might as well have been amputated. All right? There's something called a frail chest. Okay? Anybody know what that is? Okay, it's where you got several rib fractures. Okay? And you have a segment of chest wall that will move independent of the rest of the chest. It's very painful. Rarely you'll get hypoxemia from it, but they do have problems breathing. They may have sub-Q emphysema and can affect their oxygenation of their blood, but usually not. Okay? That's only if they have lung damage. And you guys know me, I have pictures. Oh no, what happened? Okay, so right here you see we've got some damage to the chest wall, so when you breathe in, instead of the lungs, the chest goes out, but this segment will go in because of the negative pressure. Okay, negative pressure is what pulls oxygen or air into our lungs. It'll also make that segment fall into the chest. Okay, when you breathe out, it'll make it blow out. So that's called paradoxical movement. It's moving the opposite way as the chest normally moves. Y'all got it? Is it clear? May not be obvious, paradoxical movement, look for wounds. Some of these have cardiac arrhythmias 12 to 24 hours later because of bruising of the heart. And then how we treat these, no, it's not X. Now, of course, any age or breed is susceptible to trauma. History of trauma or not being supervised, I don't know, he came home that way. We get that all the time up in the clinic. You'll see respiratory distress, reluctant to move, lethargy, or anorexia. They are extremely painful. Okay. How you diagnose it? History and physical. You could confirm it with radiographs. Like I say, don't have tunnel vision. Look for concurrent injuries. All right. Always take orthogonal views. Always take orthogonal views. Don't be that vet that gets out there and practice and only takes a lateral. Okay, always take the orthogonal views. When I was a first-year student in vet school, they showed us a bunch of radiographs, and one of them looked like a bunch of tumors in the chest. Actually, it was a bunch of grapes sitting on the dog's chest when they took the x-ray. So that's why you take orthogonal views. So you know if it's here, On this view, it's here, you can get an idea where it's located, okay? You don't always have to treat rib fractures, okay? Treat as needed for the condition, so pain meds, fluids, oxygen. An isolated rib fracture you can leave alone, it'll heal on its own. But if you must, these are some techniques you can use to repair rib fractures. Some wiring, pins and wires of various types. For frail chest, what we do is take a big piece of plastic, molded, put some holes in it, and then we run suture around the ribs and pull it up through that plastic. It's kind of like a brace. So that's how you treat the frail chest. Complications, prognosis, highly dependent on the cause and concurrent problems. Okay, if they're young and they're relatively healthy, you're probably going to have a good to excellent prognosis. All right, neoplasia. 3 areas you got to think about: chest wall, pulmonary, and metastatic. Okay, metastatic is the most common. All right, and there's many types. If it could break loose from its primary tumor and get in the bloodstream, it's going to land anywhere where there's a big, rich capillary bed. So lungs, liver, kidneys, all right? Primary neoplasia, diaphragmatic and right lobes are the most common location for that to happen. Primary neoplasia, you're thinking adenocarcinoma. You can't have osteosarcoma, fibrosarcoma, and hemangio, but that's a little rare. Hemangiosarcoma is more common in the heart, and it's more common to be a metastatic disease to the lungs, not a primary. Okay. Physical, you'll have a non-productive cough, you may have hemoptysis, fever, lethargy, exercise intolerance, weight loss, dyspnea, and anorexia. They look like they have cancer. Okay. Nodular density on radiographs, or you may have a disseminated infiltrative pattern or mixed bronchoalveolar pattern, but 25% of them have no clinical signs. You might have periosteal bone proliferation on all the limbs, okay, the metacarpals, metatarsals, radius and ulna. You see that, look for a tumor in the chest or the abdomen. That's called hypertrophic osteopathy, all right? I cover it more in musculoskeletal, but I can tell you I've seen that, and when we looked at the chest, the dog had 75% of his lung was tumor. And they said, oh, no wonder he's gotten a little slow lately. I'm like, really? Just a little slow? They brought him in for swollen legs. Okay? That was military working dog. Diagnosis, radiographs, CT, MRI, ultrasound might help. And ultrasound is really helpful for getting biopsies, fine needle aspirates or true cuts. You can do thoracoscopy to evaluate and biopsy it. Blood work is usually non-specific. You may see a non-regenerative anemia, leukocytosis, and hypercalcemia. But 25% of them have normal lab work. Anytime you see high calcium, look for cancer, okay? All right. Differentials for things you see in the chest could be abscesses, granulomas, fungal disease, okay? So you need to get a biopsy to diagnose it. How you treat it, you can remove primary tumor, chemotherapy, radiation therapy, surgical wide margins or removal of the mass and draining lymph nodes. But this right here, that's kind of hard to treat surgically. I think you can appreciate that. Okay. Here's a mass in the cranial lung lobe. It's got air surrounding it. All right. That you can remove, this you can't. Okay. Prognosis depends on the type. Okay, it depends on the extent of involvement. Okay, if it's an isolated nodule, you can probably remove it. If it's that chest that has it all throughout the lung lungs, that's bad. small bags of dog food. All right? So all these things will tell you about the prognosis, if it's well differentiated, if it's non-metastasized primary lung tumors, periphery, or near the base of the lung, whether or not the lymph nodes are involved. Cats tend to fare worse than dogs, okay? Pulmonary abscesses, all right? It's usually caused by something else, okay? A penetrating wound, migrating foxtail, fox, you know what I'm talking about, little seed heads, foxtails. Signalment and history. Signalment, usually the dogs that run the fields will get abscesses. You know, hunting dogs, the ones that go, you know, running around nature. They'll run and drive a stick into their chest and get an abscess. History, fever, cough, respiratory distress, weight loss, lethargy, anemia. Could be hours, could be days, could be weeks, okay? Physical, variable, okay? Just depends on where it is, how long it's been there, and all that good stuff. Usually they are febrile though. How we diagnose it? Radiographs, ultrasound, CT, lab work, okay? Lab work can be normal to leukocytosis, okay? Look at left shift, non-regenerative anemia. That's what LS means, by the way, okay? Differentials, granulomas, parasites, neoplasia. You can try to medically manage these guys. You stabilize them, you do thoracentesis, antibiotics, culture